So before we get started with what we need to do today, does anybody have any questions about any of the assignments? So the NCSBN position paper or your professional development paper? Is everybody good with those?
Do we have to do a presentation for that too, or just a Word document is good enough?
For which one? For
The
the
NCBSN.
NCSBN?
Yes.
All right, so for the NCSBN, it's just a Word document. So for that page, I know it says presentation, but it's just that it's 3 to 5 pages as well as a cover page and a reference page. So you'll read the first 18 pages of the NCSBN position paper, which you can download right through your Canvas shell. And then just follow the rubric and the assignment guidelines. Yeah, but you don't have to do like it's not a formal presentation or a PowerPoint or anything like that. So just a paper.
Thank you.
Yes, sir. All right. So homework grades are still on. Be turning them off next week. So you'll go back to just seeing your KGA. So we're gonna finish up chapter 17 today. And then I have some more practice questions that we can do. How did you guys, anybody, I know a couple of you did, but did anybody do the practice questions that I posted in the announcements? How did they go? Good?
The delegation questions?
Yes.
Yeah.
Yeah. I figured they may be helpful just as you keep moving forward and then of course getting ready to take Cassie. Yes, Tevi.
I'm sorry, I had to unmute myself. I noticed last time we took an exam, I think like that night we knew our grade. Will it be like that tonight?
It may, I have a meeting right after class, so I will get them posted as soon as possible. All right, so I am going to share my screen, and we will finish up chapter 17. And then, like I said, this time I think I forget what I chose for questions. I think I chose priority for questions, but I have some questions that we'll do afterwards. So I will share my screen. All right. So when we look at some of the roles as future nurses, to be a charge nurse, and it depends on where you're working. A lot of times when you're working a unit, depending on how many nurses are working that unit, a lot of times you are automatically in a charge nurse position. But generally speaking, charge nurses will require at least a minimum of 1 year experience. That just kind of allows you to get to know the facility, the policies and procedures, how the units are run. Obviously, your license will need to be current in your state of practice. And some of the standards that are expected as charge nurses. Excuse me. Collaboration with the IDT or the interdisciplinary team, right? Working with PT, OT, speech therapy, your case managers, your discharge planners, your admissions, and dietary, whoever else might be part of that team. You'll assist the director of nursing in new employee orientation. So that's one of the reasons why it does require that, at least a year of experience. So that as new nurses and new CNAs come in, you can assist them in orientation. And then you'll also be responsible to evaluate your nursing assistant performance, which that sometimes, is new for some people, not know, they have to evaluate the performance of others. So some of those wonderful responsibilities. Know the conditions of all residents know the conditions of all residents at all times. So depending on what type of a unit you're on, whether it's a long-term care unit, a skilled care unit, memory care unit, you need to know all of your residents, and what's going on with all of those residents. You'll assign tasks to nursing assistants. So that requires you to get to know your nursing assistants, right? What their abilities are, what their skills are. All CNAs are going to have the same basic skills, right? But some are going to excel in certain areas. You'll provide care within your scope of practice by policy and procedure and under a physician. Orders, hold on. All right. You'll assist with therapeutic and other procedures. Anybody want to do wound care? I love wound care. So that is one of the responsibilities too. And when it says assist physician, if you have an organization where they have like a wound care provider that comes in, whether it's a nurse practitioner or a doctor, you'll have to do wound rounds. So you'll take notes, make sure that the treatments are updated according to what they are asking for. Recognize symptoms of pending adverse developments and then report those. So that goes back to knowing the conditions of your residents, right? What's going on with them. Give meds, perform treatments, make sure you're documenting, right? Because if it wasn't documented, right, it wasn't done. So always make sure that you document, make sure that you ensure appropriate and organized care in the department, which nobody likes to walk into chaos, right? So if, being really organized, good time management skills are always going to be your best friends, and that calm demeanor, right, in chaos. Ensure delegation appropriate tasks to the appropriate individual. So that again, that's your Nurse Practice Act, your job descriptions, right? Making sure that you know your job descriptions of your CNAs as well. I think I mentioned this earlier. CNAs, you're trained to do vital signs, and other tasks. But in that organization that you may work, like I've worked for organizations where even though CNAs are trained to do vital signs, the organization itself didn't allow CNAs to do vital signs, right? So you have to not only know what their scope of practice is, but also that's why the policy and procedures are important to know as well. I've worked in some where CNAs had to have their CPR certification. I've also worked in some companies where the CNAs are not required to maintain their CPR, right? So just kind of varies. Ensure a safe environment for residents as well as the team. Maintain privacy and of course dignity. Dignity is always going to be a super important thing, as is patient privacy. So some of the duties as a charge nurse, or even just a nurse on the floor, obviously reporting and observing any symptoms, conditions, any changes that occur. Make sure that you are passing your medication safely, following the 9 rights of medication administration, doing your 3 checks, right? Always identifying your clients too. I will tell you prior to EMR, who's ever worked in a long-term care facility as either a CNA? Okay. So one of the biggest, you go to the hospital, what's one of the first things that they do, right? They put an armband on you that has your name. It has a nice little barcode on there, right? So who your patient is. You can scan their little ID band. In long-term care, sometimes they give them armbands and sometimes they don't. And then even when they do give them armbands, they tend to disappear. Ever notice that? They just, I don't know, one day they're there and the next day they're not. So identifying your patients and then, things like dementia and other things may kind of inhibit your ability to identify your patients appropriately. A lot of your EMR systems now, they put pictures in there. Do you guys have that where you guys work do you have pictures on your charts to know who your residents are? So that was a life changer for me, because you might have 2 older men in the same room and they may look similar and, or they may switch beds or, if they're in the hallway, you're trying to figure out who's Mr. Jones and who's Mr. Smith. So, look at medication administration, always make sure you're looking at that. Again, your documentation, your vital signs, your meds, your treatments, making sure that you're notifying providers, of changes in an appropriate manner, making sure that you're documenting any orders received, communicate with the pharmacist, maintain physical, social, and psychological environment, making sure that we're doing a good shift and handoff reports, talked about assigning tasks. You're going to have to go to care plan meetings, department meetings. A lot of places have what's called like a stand up, which is first thing in the morning, usually, with the administrator, the DON, and other key department heads, just to give status on any changes, or any issues within the unit. So, and then of course, there's always the regulatory codes and guidelines that we have to follow. And these are plentiful. And so the long-term care environment, or long-term care setting is, what's the word I want to use? It is very regulated. Okay. It is very controlled. It is very regulated. And there's lots of rules and lots of regulations and guidelines that must be followed at both the state and the federal level. And the book, we call it the Big Red Book, is your state guidelines that are published by, I think it's the Department of Health and Human Services. And that book is what they use when they come in and they do the state inspections, yearly or periodically, depending on what is going on. And that you have to make sure that, the facility has to make sure that they're within the guidelines. It doesn't just cover nursing, it covers everything. Environmental services, the dietary department, therapy, nursing. So understanding the guidelines and making sure that everything is being followed appropriately. And then, of course, orientation of new team members. So what are some things that you need to know? Your facility organization. So we talked about your organization, your org chart, right? Where you fall on that org chart. Who do you report to and who reports to you, is important. So if there's issues and you need to go up, who do you go to? Is there a supervisor? Is there a manager? Or is there an assistant DON or a DON? who do you go to when something happens, as well as who are you responsible for. So one of the things as a charge nurse, like I said, is you may have to evaluate your CNAs, right? So you may have CNAs that are going to directly report to you as well. Skills checklists for staff. Once you get out of nursing school, you have all the skills that you have to perform in order to get out of nursing school. Once you go into a facility, there are still skills checklists that need to be done. Usually it's, on hire. They'll make sure that you can perform all the necessary skills for your position. And then usually there's some sort of a skills fair or a yearly check off, right, that you may have to complete to make sure that you know how to use all the equipment, that you can perform necessary skills. And that's going to be dependent on where you work. So, how to put a Foley catheter in, how to take it out, how to perform trach suctioning and trach care, oral care, bathing, repositioning. Trying to think of what else we used to do. IV starts, that's going to depend on where you are working to. A lot of places contract out for, they'll have people that come in and will start IVs, especially in the elderly population. IVs can be very difficult to start because their veins are smaller. They, generally don't drink as much. So, it's a little bit harder to get that IV started. Maintaining, IV fluids. Can't remember what else, but there's a pretty long checklist. How to use the glucometer, right? And like I said, they're usually done on admission or on hire. You'll you'll get checked off on your skills, and then it's usually a yearly check off. You'll also again have to know the job description of those that you are working with, your CNAs especially, and those regulations. CMS is the Center for Medicare and Medicaid Services. So for long-term care, that is where we get, our money. And so making sure that we are with that proper documentation is super important. Joint Commission, I will say about Joint Commission. So Joint Commission is an accrediting body. They accredit long-term care, they accredit hospitals. A lot of your long-term care facilities are not Joint Commission. Now they may or may not be. So just for an example, one of the organizations that I worked for, we had 7 long-term care facilities. We had 30 assisted livings, and an independent living. And out of all of the 7 long-term care facilities, we only had one that was Joint Commissioned, accredited. It costs money for accreditation. So they just chose to accredit one of the facilities versus all 7 of the facilities. They are just like state can come in once a year, so can Joint Commission and kind of come in and do their accrediting process as well. The National Patient Safety Goals are another thing that you should have an understanding of. Like your reducing your hospital or your healthcare associated infections using the, at least 2 patient identifiers, which normally we all go for like name and date of birth, right? Because those are usually the easiest ones. But there are others. And then, of course, other accreditation standards. So there are other accreditors out there other than the Joint Commission, for hospitals, like DNV is one. Those are the 2 big ones that I know of. And like I said, they'll have to come in, they'll usually do a yearly review. And so one of the best ways just to protect yourself as well as the organization that you work in is just making sure that you hold yourselves to those standards all the time so that when they come in, it's not a big rush to start changing and fixing things. Personal policy or personnel policies, employee manual. So your employee manual is kind of like your nursing student handbook, right? It kind of gives you some of that information that you may need. Timesheets, most places have automatic timesheets, or there's an app on your phone that you can keep track of your hours. Now, of course, if the time clock's not working, there may be some, what do you call it, paper sheets that you may have to turn into HR. Know your payroll policies. If you want to take leave or take time off, um, how much, how soon do you have to put that time off in request? Do you need to put it 2 weeks in advance, a month in advance? This depends on your facility and how often they do their scheduling. Communication and reporting, break rules, right? So do you get 2 10-minute breaks and then your 30-minute lunch, or do you not get breaks? And so, take a 30-minute lunch. Do you get paid for your lunches? Do you not get paid for your lunches? The smoking policy, and that's not just for employees, that's also for residents. So some facilities have residents that are smokers, understanding the policies regarding that. Some facilities are completely non-smoking, so there is no smoking for anybody. Personal device use policies, and this is a big one. And I know everybody has seen it either on Facebook or Instagram or wherever, where nurses are consistently getting in trouble for using their cell phones, right? For taking and posting videos that are not appropriate, or could potentially be HIPAA violation. Everybody has a cell phone nowadays. Everybody carries one. Be very careful when you're using your personal cell phones at work. Even if you're, taking what you assume to be I guess an innocent selfie or a picture. If you catch a resident or another patient or family member, that could potentially cause you some strife later on. So be very careful with that. I know, like, we use cell phones. We carry unit cell phones so that if we have to page providers, that we have the cell phone, we don't have to run up to the desk. Family members can call the cell phones as well if we need to, get, orders or approved, right? We can use the phone, but just be very careful. And then know what your uniform is. What the proper uniform is. A lot of facilities are color coded, just like the hospitals are, right? RNs wear one color, LPNs wear another, CNAs may wear another. Some facilities just, whatever, as long as you look appropriate. And I'm a stickler for this, but make sure your uniform, and I'm sure you've heard this in school as well, but make sure your uniforms are clean, they are wrinkle free, that they didn't, look like you just had them balled up on the floor in the corner of your room, and just throw them on and roll into work, right? It just doesn't look professional. And think how you would feel if you were laying in a bed and you were sick and somebody looked like disheveled and came in to take care of you. You might have a little, first impressions. You have to remember that. You can be the best nurse, the best aide, the best doctor. But if you look like you slept in your clothes or they were, balled up in a corner, right, that kind of ruins that impression. So know what to wear, know what your footwear requirements are. I know Crocs. Everybody loves Crocs. I don't like Crocs. But just know what the requirements are. I will tell you why I don't like Crocs or any, I won't even wear, and I know just like in nursing school, I don't wear canvas shoes or or not canvas or vinyl or, no, I don't wear canvas shoes to work. Um, I always wear leather, and it's because leather generally is waterproof. I was working one, overnight. This was like 7 years ago. And we had a resident that had a Foley catheter, and the CNA had gone in and she had emptied his Foley, and then did not close, it didn't clamp the Foley bag completely. And he was a very heavy wetter, plus he was on IV fluids. And so when I walked in the room at 2 o'clock in the morning to hang his IV bag, um, I walked through a yellow river because his Foley bag had drained all over the floor and I was literally sloshing through. And if I had had vinyl shoes, or if I had had canvas shoes or Crocs on, my feet would have been soaked. So that is one of the reasons why I'm like very big. I only wear leather because I was like, that will not happen. Um, Records and department routines. So what is the routine for each of the shifts? Days, nights, evenings, weekends? So each shift usually will have certain things that they are responsible for. Um, Night shift gets a lot of the overflow, right? Generally speaking, because it's a little bit less intensive at night. Sometimes, not all the time. But they may be the night shift might be the ones that are doing like your chart reviews, your medication reconciliations, changing out your oxygen tubing, your nebulizer tubing, making sure your tube feeding supplies are good to go for the next shift. Um, Days and evenings do a lot of your charting, your skilled charting, you're getting your doctor's orders. Um, and then weekends, maybe a little bit different. So it really just depends, but there's usually some kind of additional duties that are needed for each shift. What are the reporting methods? So how do you do your shift turnover? Is there a 24-hour report, or is it just in the charts? I will tell you personally, as someone, I've said this before, long-term care and pediatrics were my two primary specialties. I always do walking rounds. Okay. So I come in, I get the nurse that is leaving, and we walk and we go to every single room. Don't always have to go in and, in each room, but we will look in each room. I've had I've had issues with some of the part-time nurses, especially on weekends. They want to just throw the keys and run. And I had this happen to me a couple times where they're like, here's your report, here's the count, and just kind of run out the door. And I go to do rounds and I found out that I've had like 3 admissions that day and didn't even know anything about them. So I always do walking rounds, give a little bit of a S-bar turnover with each resident. Each facility may have different requirements. I've also seen facilities where the offgoing nurse will record a report for the oncoming shift to listen to. So I thought that was pretty interesting as well. Where are your procedure manuals? Most places do not have like a physical copy of a procedure manual. They may. A lot of it is kept online, just because it's easier to update if it's online, but knowing how to find it. Where are your nursing care plans? Charge nurses will help to update those care plans. If you have a Pyxis, there are many long-term care facilities that use Pyxis. Most of them are still using med carts. You may have a Pyxis for like an emergency backup or other medications that may be needed in a pinch. But generally speaking, they're med carts. You'll go to the care plan meetings, transcription system. You may have to, I don't know how much you'll have to work with transcription systems. Mostly that's providers, but knowing if it's there. And then your clinical references. So everybody who knows that big skills book that you guys got right at the beginning that shows all of your skills that you'll ever need to know. A lot of your facilities actually use that book as a reference. So let's say you have, a patient comes in and needs a procedure that you haven't done in a while. A lot of facilities will have that book available for you to go to in order to look to see how to perform that skill or to refresh yourself on how to perform that skill. So it is kind of handy. And then, of course, there's always, I've seen people go on YouTube, right? Like I forget what it was. We had a new piece of equipment that was coming in. It was patient specific. And it for some reason I think it came with the patient, so it was like not new equipment for the patient, but it was something new for us. So we had to go to YouTube to learn how to do it because it didn't have, like, he had it for a while, so it didn't have he didn't have the user manual or anything with it. So knowing where to find those, resources. Other things, the admission process, the discharge process, the transfer process. Um, and this is another thing too, I'm going to tell you that's super important. And those of you that are CNAs may understand this. Anytime a resident or a patient comes in, do an inventory list of their belongings, their clothes, their shoes, their jewelry, even if the jewelry isn't coming off the finger, okay? Always document their dentures, their glasses, their hearing aids, everything. If they have a phone, if they have an iPad, whatever it is, make sure that you have it all documented in their charts. What to do if somebody passes away. That's another thing, as far as the procedures for the facility. We know that your postmortem care, right? That's going to be patient specific. Autopsy permits, preparation, your authorizations for procedures. Long-term care, there's a lots of different authorizations. So they'll sign like an overall authorization for care. But even some of the specific medications, they're going to require, separate authorizations, especially for the use of antipsychotics and those types of medications. What are the visiting hours? And then side rails. If you know anything about long-term care, we don't use side rails anymore. They may have like a little short side rail at the top of their bed that if they are able to, they may use that for positioning, but generally speaking, there's no side rails. We don't use chair alarms and bed alarms in long-term care. If you're working in the hospital, though, you will need to be familiar with those pieces of equipment. We don't use restraints in long-term care. However, if you're in the hospital, then you may use restraints. Patient transfer and transport. Your body mechanics, remember, back injuries is the #1 injury in nursing. So making sure that you're using those proper body mechanics when you're working with your residents. Door alarms. One thing that's not on here is what we call wander alerts. Has anybody heard of a wander alert? Nobody's heard of a Wonder Alert in long-term care?
Yes,
Like
when
a
they
Wonder
can leave
Guard?
out that part of the facility.
Yep, so it's a little like an air tag type thing. It goes on, it's like a bracelet, so we'll put it on their wrist or their ankle. And what that is for residents that wander, like some of your dementia patients, that like to wander around the facility. So for for patient safety, okay, they'll have a wander alert so that if they try to leave the building, it will lock the doors and alarm so that somebody can go assist them. Knowing about your standard precautions, has anybody heard of enhanced barrier precautions?
The cream.
Jordan, yep. Jessica, okay. So these are for things like patients that have tube feedings, wounds, IVs, catheters. Trying to think what else can be your trachs. These are enhanced barrier precautions. Then they're not, we're gonna use isolation for PPE when working with these patients just because they have a line or tube feeding or something along those lines, it increases their risk for infection, right? So we use the enhanced barrier precautions when working with those. So knowing those policies and procedures as well. Security policies. Where's your oxygen, your suction material, how to use the beds, any respiratory equipment. My first facilities that I worked with had the old crank beds. And they were horrible because if you didn't put the little crank in and somebody walked in the room, you'd smash your shins on the little crank, and that was particularly painful. How to order through dietary, what's the tray service, who delivers the food, where is the snack bin, what snacks are available for the residents, the specific diets that are available through dietary, dining room processes. If the family wants to order a tray, what is the process for that as well? It's like, what else? Morning and evening care, right? Making sure most places, especially in long-term care, will have shower sheets. If you have 175 bed facility, it's impossible to give 175 people a shower every day, right? So we try to break those showers up, so that people get showers at least twice a week. And they're split up amongst the different shifts. Oral care, bed making, how to do your vital signs, catheterizations, enemas, suppositories, counting your INOs, how to collect and label your specimens, colostomy care, glucose monitoring, NG and G tubes, your postmortem care, again, your standard precautions. Narc counts. So narcotic counts are done every shift change. So you will count with the off-going nurse. You'll go through all of the narcotics and making sure that the counts are good. If the counts are off, you need to know what to do. If that case, what else? All right, so talked about most of that as well. All right. So data collection. So what are some of the things that we need to look at? So obviously your head to toe assessment. So you can just break it down into that, right? Your respiratory, your cardiac, your urinary, your GI, signs and symptoms are going to be something that you are always going to collect. Again, it depends on where you work, which type of or which type of residents that you are working with. You don't have to do a head to toe on every single one of your residents every single day. All right, but knowing your residents will help you to detect any changes that may occur. So I'm going to stop sharing. So working with people, all right. So working with people can be very difficult, and we know that, right? It's one thing to say that you are responsible for yourself and your actions and what you're supposed to do and getting it done. As charge nurses and leadership roles, right? We are working with other people. We are responsible for them performing their positions appropriately. And you know, it's difficult when you're working sometimes with many different personalities, many different attitudes, right? Can be a little challenging. It can be difficult for some people to not react when people talk a certain way, act a certain way. Um, you will be in a leadership position, so kind of keeping yourself calm and not reacting, right? We said silence way back in the beginning, right? We talked about communication. Silence is an effective form of communication. If you feel like yourself, like you're escalating because a CNA is talking a certain way or another nurse is acting a certain way, take that silence, right? Think about what you want to say prior to opening, you know, your mouth and you know, saying something that you may not want to say or may regret saying later. People call out for a variety of reasons. People have issues at home. And as much as we try to say, leave your problems at the door, right, before you come into work, we know that that isn't always a possibility, right? Things affect us 24 hours. And so try to be the calm, try to be the supportive, empathetic person to assist them. And even, you know, suggesting other resources. Um, and you will, like I said, you're going to be a leader. So people are going to need to come to you to, if they don't know how to do something, you know, if they are unsure of, you know, a specific issue with a patient or a client. So you're going to be that role model for many people. If somebody says they don't know how to do something, like us, my biggest thing is see one, do one, teach one. Is a very effective way to teach not only CNAs or other nurses, but even your patients that you're providing education to. If they don't know how to do something, show them how to do it, and then have them show you, you know, what they learned, and then have them teach somebody else that process. It helps to reinforce. I cannot tell you, and those of you that are CNAs, okay, say thank you to your CNAs, appreciate your CNAs. CNAs are the backbone. I mean, we nurses do a lot, but your CNAs, they do their work is backbreaking. Okay, it's, you know, you as you know, us as nurses, yes, we're passing medications, we're making sure treatments are done, we're, you know, worried about the stability of our clients if there's something going on. But your CNAs, they're the ones that are really, you know, they're going to know a lot about your patient, things that you're not going to know, you're not going to see. And, you know, treating them with respect, always saying please, always saying thank you, really goes a long way. If they do a good job, tell them they did a good job. don't just be like, okay, see you tomorrow. Like, no, say thank you. Hey, you did great today. If there's something specific, that you want to point out, say that. If something happens and you have a CNA that's not performing, and you have to have that conversation with them about their underperformance, okay? Always try to start with something positive, all right? It's a lot, a lot of times when we think of, having these conversations or we know that there's a lot going on and things happen. But everybody does something well, right? Everybody does something well. And so try to start it off with something that they did well and then tell them, hey, okay, so you did this really good and you're really good at this, but I would like to talk to you about this, okay? So try to start it with positive and then, kind of go to them and, give them some tips for improvement, and provide constructive criticism. Don't just be like, this is what you did wrong and you just need to fix it. Tell them what they did wrong, tell them how they could, do better. And then look and, kind of what's the word I'm looking for? Collaborate with them, right? To identify ways to help them improve. Because if you build that collaboration together, it's going to work out better. And then the last part of this is dealing with family members. Who's ever had to deal with an upset family member? Who's been an upset family member? All right. So we can look at that on either side, right? So, as nurses, that is, something that we also have to look into. We do have to we're taking care of our clients, but we're also having to deal with the family members, right? And what's going on with them, and the clients themselves. Patients get upset too. They get mad, they get angry. And so what do we do? Build a relationship, building the rapport with your clients and your families is going to make your life a lot easier. If you have a positive relationship, right, that's a lot, easier to deal with than if you start off on the wrong foot. Let them talk, let them express their feelings, not just for the family, but for your clients as well. And realize that when they get upset and they yell and they're frustrated, it's not always something that we did or didn't do. We have to remember that too. We're dealing with patients in the worst days and some of the best days of their lives, right? And so the frustration that they are often presenting just could be the loss of independence. It could be fear, right? It may not necessarily be something that we did or didn't do. So allow them to talk, right? Some people, sometimes you just need to yell, right? Or you need to, you know, say what you need to say, and then you're fine. So just listen to them, let them, share their feelings, try to figure out what it is that that they need. Sometimes they don't know, right? Sometimes they don't know. They just need to, get whatever frustration out, and then try to come to some sort of a reasonable conclusion that everybody will be happy. But again, developing that rapport with clients and families is going to be your best friend. And providing education. So a lot of it is too, it's lack of knowledge. And so the more education, the more information that we can provide to them will, help them to feel better. It'll help to empower them so that they can feel like they have a little bit more control over the situation. Imagine being sick and laying in a hospital bed and not really knowing what is going on. That can be extremely frustrating. So just be respectful of that and try to help as much as possible. All right, so that was the end of chapter 17. So I have some questions. I think I chose 15 questions. Yes, I chose 15 questions. So we have, what do we have? We have about 15 minutes. So we should be good for those. So I will share my screen. All right. So again, I think these were prioritization questions. So we have a newly hired nurse experienced harsh criticism from the preceptor during orientation. Upon completing orientation, the charge nurse assigned her the most difficult and complex patients. What would the new nurse do first? This is a good one. Use assertive communication to discuss the assignments with the charge nurse. Talk to the nurse manager about the behavior of the charge nurse and preceptor. Make a formal written complaint and submit it to HR, or review the facility's policies on horizontal violence like bullying and harassment. So what should we do first? All right, so one is and that is correct. The first action would be to talk directly to the charge nurse about the assignments. And it can be difficult, but assertive communication can be carefully planned and then delivered with a calm and non-confrontive tone of voice. Other options may be considered if the nurse continues to experience harassment or bullying. So good job. Awesome. All right, next question. Which assistive personnel needs a reminder on providing denture care? So places a towel in the sink, then fills the sink with an inch of tepid water. Puts on gloves and grafts the front teeth to remove the upper denture. Brushes all denture surfaces with a brush using a commercial paste, or rinses the dentures with hot water and stores them in a clean, dry cup. So which one needs a reminder? All right, so let's see. All right, so I had some others, but 4 is the predominant one. So 4 is correct. Hot water can warp or soften dentures, so we use tepid water for cleaning and rinsing. And they are, stored in a labeled cup with cool water. All right. Which specimen collection method is the most important to modify if a patient has a low platelet count? So blood serum sample, stool sample, midstream urine, or expectorated sputum sample for culture. Low platelet count. All right, we'll go with number 1. Very good. So platelets are necessary for blood clotting, right? So if we have a patient that has low platelet counts, they may not clot very well. So if collection method, right? We would have to use a much smaller needle, making sure that we're providing some really good pressure after we draw the blood. But yes, so we would have to modify their serum, their blood sample. All right, good job. All right, before the end of the shift, the nurse is rounding on assigned patients and performing a quick head-to-toe assessment. Which patient has the priority finding? So a patient with kidney stones that has 7 out of 10 pain, an opioid naive patient that has slow, shallow respirations, a post-surgical patient has pale, clammy skin, or an elderly patient is more confused compared to baseline. Who is going to be priority here? All right, so we got 2 was the high ranking answer. So very good. So opioid naive, what does it mean to be opioid naive? And I know you guys saw opioid and shallow respirations, and that was key, but what does it mean to be opioid naive?
You don't understand the cause and effect of the medication that you're taking.
So that is the definition of naive. Absolutely. So when you think of the word naive or not understanding, what is another thing that comes to mind with the word naive?
Like people may expect just because they're taking opioids that they're automatically going to be addicted or it's something wrong. Like they think they're right when they don't necessarily know the full situation.
Okay.
Ignorance.
Okay.
Easily influenced.
Say that again.
Ignorance.
Easily influenced.
It's a
Easily
patient that
influenced.
is not
Okay.
has not been really taking opioids at all, so they don't really know the effects of the opioids. So, say for instance, if they've never taken them, the side effects can be severe.
Right. So yes. So naive is all of those things that you said. And absolutely. And so when we talk about opioid naive or even another medication, it's somebody that has never taken that before. So they've never taken opioids before. Um, and so they're, if they've never taken them before, right, we don't know how they're going to respond to them. So they may have some more, of those adverse effect that we would see, just because they've never had them before. Their body is like, wow. So good. I mean, you guys came up with the correct answer, and that was absolutely perfect. But I did not know if anybody had heard that term before. All right, which guidelines are included as good body mechanics for lifting and moving? So bend forward from the waist, or this is select all that apply. Are we going to bend forward from the waist to pick up objects? Use thigh, arm, or leg muscles rather than back muscles. Elevate the bed to work at a height that minimizes bending. Keep the trunk straight. Don't twist when lifting. Use a wide base of support, feet apart at shoulder width, and push objects away rather than pulling them towards. So good body mechanics. All right. So what do we got? We got, oh, I need my glasses. I don't know why that's so small all of a sudden. 2, 3. All right, so we definitely got 2, 3. 2, 3, and 5 and 6. And then someone also picked 4. All right. So correct answers are 2, 3, 4, 5. So goal is to decrease stress and strain on the back muscles. So use those larger muscles. Working at a comfortable height. Know that we've, put that bed up. Keep the back straight, wide base of support. And then I don't know. All right. What else? Pushing objects utilizes the upper and lower back. So pulling instead of pushing. All right. Next one. Which incident would involve the State Board of Nursing in fulfilling its primary purpose? So older experienced nurses receive less pay than a recently hired new grad. Nurse experiences sexual harassment from a supervisor and healthcare providers. Nurse is practicing with an expired license and fails to assess a patient's cast forearm. And then several nurses were fired by hospital administration for trying to start a nurses union. Can't even say the word. So 3 is the popular answer, and that is correct. Awesome. All right, which documentation entry needs to be flagged so that the general guidelines for documentation can be reviewed with the nurse who made the entry? So what are we looking? This is looking for something that's not correct, right? So 1330, Dr. Smith reviewed and explained surgical procedure, consent form signed and witnessed. Number 2, registered nurse assesses patient's pain 7 out of 10 and administers morphine as needed. Next one is sacral wound irrigated with 100 mLs of sterile normal saline, pink tissue, small amount of serous drainage noted, or liquid and nutritional supplement refused. I don't like the taste. Other flavors offered but declined. Which one of those needs to be fixed? The toss up so far between 1 and 2. All right, I'm just gonna go with, I'll go with 2. All right, 2 is correct. Documentation should be done by the health team member who performs the action. All right, so I don't know why, why she would document that somebody else assessed and gave pain medicine. So it should be the person that actually did the action. All right. Which nurse is most likely to be held liable for nursing malpractice? Nurse A assigns too many patients to AP. Some do not get a shower, so your assistant personnel. Nurse B fails to report worsening condition and the patient sustains permanent damage. Nurse C leaves before shift report. No patient is harmed, but oncoming nurses are upset. Or nurse D is demeaning and uses condescending language and the patient gets angry. So which one of those is most likely considered malpractice? All right, 2. Nurse B fails to report worsening conditions and the patient sustains permanent damage. Absolutely. All right, the nurse is supervising the nursing student who is performing a procedure. Which action by the nursing student requires correction? So checks agency policy and procedure manual before beginning the procedure, checks the order, collects equipment, performs hand hygiene, provides privacy, raises the bed to working height, and ensures the wheels are locked, identifies self, starts procedure, and explains each step as it is performed. So what requires correction? We got 4. Correct. Student has skipped the critical elements of identifying the patient using 2 identifiers before beginning the procedure. Awesome. Great job. All right, so it is 5:27. So I will stop sharing. Anybody have any questions? All right, so I will get those test scores out to you as soon as I can. I hope everybody has an awesome weekend, and I will see everybody next week.
Have a good weekend.
Have a
Thank
good
you.
weekend.
Thank you.